o'clock. Okay, good afternoon. Thank you so much for joining us today in this series of Xiamen Sites. I have the pleasure of introducing Dr. Malaz Boustani. He's my colleague and friend, and today he's going to be giving his presentation. Let me introduce him. Dr. Boustani is a geriatrician, a neuroscience, and an implementation scientist with extensive experience in developing, evaluating, implementing, and disseminating healthcare innovations with a main focus on brain health. He is the founding director of the Sandra Eskenazi Center for the Brain Care Innovation and the director and chief innovation and implementation office of Indiana University Center for Health Innovation and Implementation Science. Over the past decade, Dr. Boustani has built a clinical laboratory of more than 2,000 ambulatory practices, serving at least 10 million lives within the 5 Midwestern states. He used the above clinical laboratory to lead the execution of numerous clinical research studies funded by the NIH, the Agency for Healthcare Research and Quality, and the Center for Medicare and Medicaid Services. He has more than 190 peer-reviewed publications, and it's my great pleasure to introduce him. Thank you, Dr. Boustani.
Thank you, Gabriela, and thank you for everyone to give me the opportunity to exchange hopefully helpful, actionable information with you all. This is very relevant to the recent alternative payment model that was approved by Center for Medicare and Medicaid Innovation Services to support the collaborative, comprehensive dementia care services starting July 1st, 2024, and for the established program like us, hopefully, and in July 2025 for other new program. And this alternative payment model will generate significant demand for providing this comprehensive dementia care services. What I'm going to focus on is one major component of the comprehensive dementia care services, which is how you're going to be working with the informal caregiver. So before I start, this is my disclosure. In particularly the slides, I have equity and multiple company that I found. Some of them I sold. I also serve advisor on multiple company that have, at least one of them have a product in the market for Alzheimer's disease. And I've been author for a couple of books and teach a graduate certificate, and I receive a lot of funding from the federal government. So this is the why of focusing on the informal caregiver. And I hope all of you know, but the informal caregiver are very crucial providers, in my opinion, for family living with dementia in particular. They are the main providers of almost 80% of the benefit of the comprehensive dementia care model. However, they have significant need, and primarily two kind of need they need. They need to have competency of how to cope with the cognitive, physical, behavioral, and psychological disability of their loved one living with dementia. And they need to know how to manage their own caregiver stress. And if we don't do that, then they become a patient already, and they end up suffering, and their health in particular decrease, including their overall mortality. And this is the theory, we call it the green theory of caregiving. That is the component, the mechanism of why focusing on informal caregiver can actually help patient living with dementia. So the theory is, and now there's been multiple clinical trials that to support this theory. So we think this theory is very solid, at least for the past 20 years, that in a way, if you have informal caregiver who have a better coping strategy, then they can have a lower caregiver stress. And by doing so, the burden, the societal individual burden of dementia will significantly reduce. So that's the mechanism of how the green theory work, or in particular, how come improving the caregiver stress in improving their competency can improve actually dementia care burden, and particularly keeping patients and family living in the community away from institutional setting. So this is the main essential component of this green theory. We call it the lighthouse for caregiver. And the goal is for you to coach the caregiver, the informal caregiver. So by doing so, you will be able to reduce the dementia burden. And the way you do that is very specific. This is the minimum. We don't compromise on this. Number one, you have to figure out how competent are the caregiver in coping with the cognitive, physical, psychological, and behavioral disability of their loved one. So that's number one. Number two, you have to find and review with them and coach them on how to implement evidence-based coping strategy. And together with the informal caregiver and the competency measure, you can develop very personalized coaching plan. And then when you do it, you have to keep your eyes if the coaching plan actually working. And the way you do it, you can figure out if the caregiver has moved to the green zone. So this is similar to exercise concept. If you heard of the orange theory, and where people go to exercise and they try to keep their heart rate in what they call it the orange zone. This one here is trying to keep the competency of the caregiver and their stress level in the green zone, meaning they're not stressed out, they are competent. So in order for us to do that, we are working with them on implementing what we call the caregiver stress prevention bundle. So again, this is really what we try to coach the caregiver on so they can actually do it. So number one of any caregiver is the coach. We need to work with them, convince them, problem solving with them to take one block of 8 hours time off caregiving task per week. Not 1 hour here, 2 hours here. It's a minimum of 8 hours time off of caregiving task per week. And not just being time off physically from caregiving task, but actually psychologically. All right. Second, attends monthly, every month, a support group. We call it the Green Zone support group. And then complete a crisis plan. Every family of people living with dementia, they will face somewhat predictable crises. One of them include financial exploitation, potential driving and car accidents, institutionalization need, when you need to go to the hospital. What about the benefit or harm of screening element? How can you manage aggression in the future? These are all crises they will face, and we can develop upfront a plan to manage these crises before they reach it. And finally, through this coaching in particular, is the care coordinator or the navigator or the coach work with the caregiver on really help them and coach them to become a masterful problem solver strategist. And in order for us to do that, we have a specific protocol and we have specific handout that are completely tied to the competency level of each person. So I'm going to walk you through that process. The big first step to create the green theory is to actually measure the competency of the caregiver in coping with the cognitive, physical, psychological, behavioral disability and their own stress. We have developed something called HABC Caregiver Monitor. This is, we call it like a blood pressure cuff. We simply ask the caregiver to look back in the past 2 weeks and see if they have a problem with or their loved one have a problem with. And we define a problem is not if the person living with dementia have the capability to perform his task, actually if performing or unperforming the task is causing stress to the patients or stress to the caregiver, then we call it a problem. And so it has around 30 items, and there's 10 items that focus on the cognitive competency, the competency in coping with cognitive disability, 10 also item on functional disability, and 10 also item on behavioral and psychological disability. And then we have 4 items that specifically focus on the caregiver, their own quality of life or stress. And based on these, on their answer, we can segment the patients into different zone. And the most important one is the green zone. And this indicates that the person, the caregiver, is competent to cope with the cognitive, physical, psychological, and behavioral disability, and they don't have a stress. All right. Then the yellow, they have some kind of competency and stress problem, and obviously the red is you are in a big trouble. So that's the goal in coaching them to keep them in the green zone. So if they came in with the green zone, we try to keep them in the green zone. If they were outside the green zone, we work with them to bring them back to the green zone. So that's the concept of green theory. The way we do that, we have a specific protocol. We have almost 33 protocol that organize based on these different disability, the cognitive, behavioral, psychological, and functional disability. And for each protocol, we have a set of handouts that our care coordinator use to coach the person. So in a way, that's how we can actually connect the green theory all the way to action. So the way I'm going to demonstrate this, I'm going to go over a case over the next 5 minutes. I'm going to read the case, and I'm going to tell you the answer for it. And that way we'll try to make connection. These cases are real cases that we had in our center, but obviously we de-identified them for their protection. So Dominic Bennett is a 70 years old person seen first in our clinic with subjective memory problem way back 2011. Then through that journey, unfortunately, he was diagnosed later on with early stage Alzheimer's disease. And then the first time when we made the diagnoses, his mini-mental status was 25 out of 30, which is like mild cognitive disability. His care partner, or now become a caregiver, is Susan, who is his wife. Both of them have been living in their own home for quite some time. And they are part of our program. And we set up a visit with the patient and the caregiver. And Susan, at that time, you can tell she's been a little bit stressed out, and she doesn't really know, what's this meeting about? What do you want to do? And you, as a care partner, as a care coordinator, you didn't know how you can start. So this is almost think about it as the first visit. And so in that circumstances, the first thing we do is technically do the following. So here's the answer. Number 1, we complete the Healthy Aging Brain Care Monitor with Susan, and then we look at the results, and we can see right away we are in the branch point. We can see if Susan is in the green zone, what should we do? And if Susan is outside the green zone, what to do? So let's start with the first. Imagine if Susan was in the green zone. And then if that's the case, then we work with her and start implement what we call the caregiver stress prevention bundle. We work with her on getting 8 hours time off caregiving task, work with her on attending support group, and complete the crisis plan. If she is outside the green zone, then we end up asking her to identify the top 3 stressor from the Healthy Aging Brain Care Monitor and start to do what we call 8-week session of problem-solving coaching cycle, where we work on one stressor at a time for 30-minute session. And for each stressor, we look at the right protocol. We have an algorithm that pick up the right protocol to work on that stressor. And for each protocol has a handout to guide the coaching session. And then after 8 weeks, we measure the Healthy Aging Brain Care Monitor again. And if the monitor is still outside the green zone, then we restart another 8-week session. So you can say it's 8-week session until you get back to the green zone. So that's, in a way, our process. Now, we'll continue with this person. Now, the caregiver monitor, the next time they interact with patient, went down from 30, which was almost in the red zone, to 22, which is kind of still in the yellow-orange zone. zone. She's been following your advice. She's been able to manage the repetitive behavior that her loved one is dealing with, but she's still finding a difficulty with her husband agitation. And sometimes this agitation, it can be dominating the entire day. Her stress level appeared to be lower than last, but she's still at loss of how to handle her husband's verbal agitation. He shout at her when she tried to help him, and he sometimes shout at other people, especially when they are at a restaurant. So that's kind of the next visit. You can see it's a constant a journey. This is why we call it longitudinal. So here's the answer. We have one of our protocols called agitation profiling, where we work with the caregiver, the care partner, the care coach work with the caregiver to define agitation protocol, set up the handout, and start 8-week problem-solving coaching cycle. Then after 8 weeks, we'll repeat the HABC monitor and see if things worked, or we have to do another 8-week cycle. Then continue on this patient's, her MMSE or cognition continue to decline. That's what you expect patient with dementia. It's now in number 17. So she dropped, the patient dropped from around 25 to 17. Now it's in a mild moderate, like on the cusp of mild moderate. The caregiver monitor, it's still going down, now 19, but it's still outside the green zone. She's been doing well at managing her husband agitation. And she also reduced that agitation by kind of protect him from overstimulating environment, following the protocol, maintain a relaxing setting at home, and all the protocol and the handout that her her coach has been working with her. But her husband is more and more now physically aggressive. Not just verbally, physically aggressive. And one time he attempted to hit her, and when she tried to help him. And now her MMSE, his MMSE, it's lower than you expected. All right. So this is a little bit much lower than what you expect of trajectory. And when we see that kind of acute change, geriatrician, like you can tell Dr. Cohen head was shaking. Like right away, she said, oh, this is delirium until proven otherwise. And here's what we do for our care partner. So sudden or rapid decline in global cognition with agitation, doesn't matter what agitation, is delirium until proven otherwise. And delirium is a medical emergency we have to figure out. So how can you identify this sudden or rapid decline if you're a care partner? This is how we do it. We could repeat an MMSE. If there's 2-point decline over 3 months, that more than the trajectory. Or you can simply ask the caregiver if the patient has been more confused over the past week or day. If the answer yes, and you don't have access to memory care doctor, you work with the caregiver to contact the primary care clinician and make sure there's no delirium. If there's no delirium, then you are dealing with agitation related to the underlying pathology of dementia, and you start the 8 weeks coaching session again. Here we can continue the same thing now, 3 years after that delirium episode that was superimposed on mixed Alzheimer's disease, vascular pathology. Both the husbands and the wife have been doing well. The caregiver monitor is lowest ever, and the MMSE is appeared to be decreasing as expected by an average person. He's been attending an adult daycare center 3 days a week. That's give Susan plenty of time for her 8 hours time off caregiving task. She has home health aide who come over and help her managing the basic activity of daily living. He's been more dependent. She's very, very grateful for your help along this long journey. All right, long journey. We're talking about 6 to 8 years. So tips at the end of the day, if you are a care coach, we have created some kind of boundary that help you manage your role as a care a coach. And the big one is if the caregiver is not putting the same effort that you are, you might need to build a trust. But whatever you can do, make sure you don't spend all your energy on disengaged caregiver, because you have a panel of other caregivers. So you have to manage your time accordingly. make sure as a care coach you have a good work-life balance by telling the people your office hours and that what to do if they have a problem outside of the 8 hours. In our program we have 24/7 process, but for our care partner we want to make sure they are protected, because care partners and the care coaches are at high risk of burnout, both of them. So we have to take care of them. And obviously each care coach needs to stay in the scope of their practice. So that's the story. It's very, very quickly, but I want to leave 9 minutes to 10 minutes for question and answer where I can zoom in to anything you guys need. So with that piece, I'm going to stop sharing, and I'm more than happy to take any question, Gabriella, anything you want me to zoom in onto it. And I can see Ambar is here. I know Ambar very well, and Gabriella. So thank you. Hey, Ambar.
Great presentation. That's really very, very helpful. And this is one of the situations that we deal every day when we're dealing with memory. So I like to see if there is any questions, or of course I have a few questions, but let's see if anyone in the audience wants to ask anything to Dr. Boustani. So I don't see anything in the chat. Do you want to say something, Amber?
Yeah, Dr. Boustani, I am always so impressed that every time I hear you, I learn new ideas and how to make this feel, with so much excitement and innovation that you're doing at every stage for the patient and the caregiver. My question to you, and I love the idea of this orange theory kind of HABC monitor. But where did you get this, that the 8-week is the right amount for the coaching to make a change?
Yeah, for us, this was based on our randomized control trial where we tested this caregiver stress prevention bundle and the collaborative care model in 2006. And that was the protocol that we developed, and that reduced behavioral and psychological symptom. It has been replicated now by similar result in Germany and other group in UCLA and UCSF. So these are evidence-based protocols that have been tested at least in 4 randomized control trials in the past 20 years.
And it does not involve giving any meds for like anxiety or depression to the caregiver, or does it?
Yeah, for us, our managing behavioral and psychological symptoms and our protocol, unfortunately, as you know, there's only one FDA approved medicine that was just approved 6 months ago. And it's a really, it's for agitation management, and we don't use that. So far, we've been able to accomplish reduction in behavioral and psychological symptom using these coaching strategy for almost 20 years. So that's been our case. In my patients, in my population, the only time if I'm going to use any kind of antipsychotic, FDA approved or not, is for people who have psychosis that lead to emergent safety concern. And even that one, I do it for a very short period of time. And don't, that's very rare. And so far in my 20 years in practice, in real world, not in the clinical trial world, I have maybe 2 or 3 patients who I had to give them short-term antipsychotic.
That's awesome.
We have another question from Dr. Patel. Can you share with us, the question is about your staffing model, and you mentioned the 24-hour access, how you manage that. Excellent question, Dr. Patel.
Yeah, so if you need more details, I think the guides model have literally replicated what we are trying to do. So I'll tell you what we are currently doing and what we are planning to do starting July if we get approved by the CMS to deliver the guide model. So our most important personnel in our guide model is what we call the care navigator. All right, that care navigator is everything, is the essence. And the care navigator is like the coach with that I described, the person who will coach the caregivers, the informal caregiver, to work with them. So the load, the panel size of the care navigator, it varies, but in our case, we can do it all the way from 75 to 125 patients per full-time care navigator. That care navigator, what is their requirements? The minimum that they need to have is a high school degree. You think of them as a community health workers, and if we go through a specific training for them and specific selection criteria, we've been able for the past now since 2013, so almost 10, 11 years, they've been able to provide this kind of caregiver stress prevention bundle. For every 4 or 5 care navigator, we have a master and social worker who is supervising them, who is there to be on demand if they need anything, and also responsible for their training. And then we have for each team of let's say 5 care navigator and 1 master in social work, we have around 10% of memory care practitioner like Gabriella or myself, and they are there just to make sure available for the agitation that is induced by delirium, for example, deprescribing certain medicine, and obviously troubleshooting for complex cases. So if the person was outside the green zone for like a couple of cycles, like 6 months or so, and then the memory care practitioner can step in with the master and social worker to figure out if there's why and what kind of modification they can do to the personalized care plan.
Excellent. Thank you so much. We have another question from Dr. Amber. Has the monitor has been tested in regular primary care clinic, the HABC monitor?
Yes, sir. So we have developed the HABC monitor in the purpose to be like a blood pressure cuff concept. So very short, doesn't require more than 6 years of education, less than 5 minutes, and you can use it for screen detection and monitoring, and you don't need a person in the middle. Like you can have the caregiver themselves, can they complete it, and it's very sensitive to change. So we develop it in primary care, in the primary care setting where we have around 55% African Americans, almost 66% dual eligible. So very very vulnerable populations. So it worked in that setting very well. We have developed it. We have now extended it. People use it actually in ICU survivors, in a trauma survivors, in people with multiple comorbid conditions. So a lot of now, ironically, the HABC monitor in use in an ICU survivor more than anybody else, because ICU survivor have similar and has been translated to multiple language, including Spanish, Portuguese, Chinese, Mandarin, Arabic, French. You'll see it. So that's the HABC kind of monitor. And we are making it now open source. We used to make it closed, but now it's open source. So if you need to, let me know.
Maybe last question. In your experience, what is the reason where the caregivers get out of the green zone? What is the most frequent reason?
Yeah,
You present with behavioral issues, but what's your experience?
Yeah, the main mechanism is they don't take time off caregiving task. Like that is the fundamental. They this is why sometimes it takes us 6 months to work with them and convince them that taking care of themselves, taking time off. And the best way we have been able to do that, like the story, is we tell them, especially those who live with the care recipient, like live with the patient home, spouse, for example, we tell them technically you are working 4.2 full-time job because you're there 24. And if you're not a saint, which to the best of my knowledge, no one has been officially saint by the Vatican or anything else, you gonna be crashed. And if you crashed, then your loved one gonna end up going in a nursing home right away. So if you don't want your loved one to go to nursing home, and so far I haven't found anybody who proactively want to go to nursing, all right, then you have to take care of yourself. And then finally, I remind them is if you take a flight, any kind of flight in the United States, one of the education, they say, if you have a person who you depend on, first put the mask on yourself before your son or your person who depend on you. So we try to convey that. They don't listen to us. We have to say it over and over and over. And that's been the mechanism that make them very vulnerable to be outside the green zone. And when we succeed, then it's the driving force to reduce our need to use antipsychotics, for example.
It's interesting. I would thought that maybe untreated behavioral symptoms could be the first reason, but the first reason is not taking care for the substance. It's interesting.
Unfortunately.
Excellent. Do we have any other questions? And I will ask you to please fill the evaluation for this lecture. And this is, we just copy this in the chat. If you could really follow this link, we really appreciate your feedback. Any other comment, questions?
Dr. Boustani, I want to know if you're an Orange Theory fanatic like me.
I am not, but my wife is
Okay.
unbelievably fanatic, and she's been nagging at me. My like is to compete with a team, and I get very competitive. And if I'm not in that Orange Theory, I get really mad. So, so I decided not to do it. But I can't tell you how much my wife has been doing it from the beginning.
Same. I'm a founder. It's addictive.
It's
I never hear it brought up
it's
in a
very
lecture.
addictive.
So yeah,
Here we
kudos.
go. So this is just for Emma. For Emmy, I think this is the code that you can go for the evaluation. Just include.
Thank you so much. Thank you. I think we are right on time. It was such an interesting lecture. Thank you so much, Dr. Boustani, and thank you to all the audience. And we see you next month with another lecture. Thank
All right,
you
take care.
for participating. Thank you.
Thank you.
And please fill the feedback. Great.
That was wonderful. I have another meeting. Thank you so much.
Thank you. Thank you so much, Emma. Bye-bye.
Bye.